This is exciting, actually. This is what we're going to be presenting here is a preview of work that is the culmination of many years of avid work to bring this sort of thing about. These are guidance statements for the treatment of acquired autoimmune myasthenia gravis. It's a landmark effort because rather than being the result of scientific investigations that in many ways are not really possible to do for a disease like myasthenia, it's a result of the consensus of opinion of a panel of international myasthenia experts. Well, to start off with, why do we need treatment guidelines for myasthenia gravis? Well, first of all, there is no generally accepted standard of care for the disease, as I'm sure you all appreciate, particularly those who have seen different doctors or who talk to your fellow patients about the way they're being treated. There is no accepted standard of care for the treatment of your disease. And it is a heterogeneous disease. It affects different people in different ways, and no one treatment approach works best for all patients. Also, few physicians see enough patients with myasthenia to be familiar with all of its clinical features and all of the possible treatments that are available for myasthenia. We feel that early expert treatment of myasthenia markedly improves the ultimate outcome. And there are very few randomized controlled trials of any form of myasthenia gravis that have been successful. But even if there were, no single randomized controlled trial of a given treatment would balance all of the information necessary to select the best treatment for each patient. And it would be impossible to do a randomized controlled prospective trial of all of the potential therapies. We're actually blessed in myasthenia that we do have a number of treatment options that are effective. Our goal then is to pick the best from the options that are available for you, the individual patient. So who other than your doctors use such guidelines? Well, I don't think I have to point out to you that your insurance company is, if not dependent upon, should be dependent upon or responsive to such guidelines. Medicare and Medicaid will depend upon that as well, as would governmental health organizations. When, for example, the NIH or another governmental agency puts up some money to develop or pursue a new treatment option, it will be to their benefit to have guidance statements already in place that they can use for that purpose. And then finally, our institutional review boards, the ones who review the research studies that we do, use these guidelines to be sure that we're not doing anything that is counter to accepted therapy. After many years of trying to get various organizations to pursue the development of these sorts of guidelines for myasthenia, the foundation, in October of 2013, the Medical Scientific Advisory Board of the MGFA appointed a task force to develop treatment guidance for myasthenia gravis, and a panel of 15 international experts was selected and convened. Along with Gil Wolfe from the University of Buffalo, I co-chaired that panel, and we were joined by Pushpa Narayanaswamy, a neuromuscular neurologist at Harvard, who served as the facilitator and moderator of this panel. I refer to Pushpa as our cat herder, because as you can well imagine, if you've got 15 supposed experts in any field together, it's going to take a strong hand to keep them in line and to pursue the goal for which they have been convened. And the foundation put up some money to sponsor the conference and to bring together this panel of experts, for which we are very much indebted. So in Durham, right down the road, we got together in early 2014 for the first time. These are the panel members who participated in the consensus conference. Mike Benatar from Miami, Amelia Aveli from Rome, where they have a very large myasthenia gravis clinic, Niels Gilus from Bergen, Norway, Dr. Isabella Ia from Barcelona, Nancy Kuntz from Chicago. Nancy is our pediatric neuromuscular myastheniologist. Janice Massey from Duke, Arthur Melms, University of Erlangen in Germany, Hiro Murai, our Japanese representative, Mike Nicole from London, and I just really appreciated today for the first time after listening to Wilma speak, how Mike got to know so much about myasthenia. Jackie Pallas, University of Oxford in England, Dave Richmond from California, and John Verschuren from the Netherlands. So these were the people who were selected on the basis of their extensive experience over many years treating and publishing in the treatment of myasthenia. Among the criteria were that these people had to agree in advance that the goal of the conference towards which they would work was to come to a consensus, even if it meant that they had to agree to some things that they didn't feel so strongly about. And the fact that we were able to accomplish that, I think, was a tremendous accomplishment and also a credit to Dr. Narayanaswamy. If only she would go into national politics and bring together some of the squabbling folks that we have to listen to these days. This is the procedure that we followed. It's called the RAND UCLA Appropriateness Method, and it's a recognized method of achieving consensus for medical treatments, among other things. You start off after having selected your panel, you do a literature review of what's known about the treatment of myasthenia gravis, and you synthesize that into a coherent body of information. You then develop a list of definitions and recommendation topics, and I'll talk a little bit detail about the recommendations and topics. For each of the recommendations that we consider, we evaluate them in 2 rounds. The first round, the panel has no interaction with each other. So the panelists evaluate each specific recommendation on their own, anonymously, and then they vote on that recommendation. And then the recommendation is edited and reviewed and modified based on the panelists' recommendation or comments to the first recommendation. And then the modified recommendation goes back to the panel, where again they review it anonymously and send back their comments. And you continue doing this until you have achieved consensus. And there's a very rigid definition of what consensus consists of in this scenario. And I won't go into the specifics of that, but as you can see, it's a continual process, refinement process, until finally you've got your experts all to agree on a statement. Your conclusions are then that we are in agreement, and also the recommendations that we make are appropriate. If they are anything other than appropriate, they are deemed to be either uncertain or inappropriate. And fortunately, we were able to get to the point with all of our recommendations that all were considered to be appropriate, and that was agreed upon by the entire panel. And then at the end of the process, you have a list of specific recommendations, and if it turns out you would have identified areas in which there was uncertainty and the need for future research. And we came up with a few areas like that, but the major recommendations all were felt to be appropriate and had reached consensus. We started off by looking at national guidelines that had previously been developed for a number of countries, and thankfully, but I'd have to say not surprisingly, there was remarkable concordance among the national guidelines. Very little difference among the experts' opinion on the treatment of myasthenia around the world, and that made our job a lot more straightforward. As I mentioned earlier, we started off by defining a number of terms that we would then use throughout the process. And these are the things that we started off by defining. The goals of treatment. What do we mean by remission? How do we define ocular myasthenia? What's a myasthenic crisis? And what's refractory myasthenia? And having agreed on the definitions of these terms, we then use them throughout the remainder of the process. And I'm not going to go into all of these definitions. Let me just say at this point that the paper of this, the results of the conference is in press. It will be published shortly. Until it is actually published by the journal, we're not able to reveal all of the contents of it. They embargo the results until they have actually published it. And that could and should happen any day now. I had hoped it would have happened by today, but unfortunately, we'll still have to wait a little bit longer. But I fully anticipate that these recommendations will be published by, well, I hate to guarantee what the neurology journal's going to do by the summer, maybe even by next week. So the foundation will certainly publicize these and make them available to you as soon as they are available. First of all, let's start off with what are the goals? What were the consensus goals of the treatment of myasthenia gravis? And these are our goals. To achieve what's referred to as an MGFA post-intervention status classification of minimal manifestations or better with acceptable medication side effects. A number of years ago, the foundation sponsored another task force that developed definitions of a number of features of the myasthenia and its treatment. And among the things that they defined were a classification system called the post-intervention status. Minimal manifestations under that definition are that the patient has no symptoms or functional limitations from myasthenia gravis, but continues to have some weakness of some muscles that is not limiting. So that is the goal, the recognized or accepted, defined goal of treatment for myasthenia gravis. So that's what we aim to achieve when we start out to treat a myasthenic patient. I'm not going to go into the definitions of these other terms because they are actually fairly straightforward, and many of them came out of the previous MGFA task force that defined things like ocular myasthenia and crisis. We essentially adopted the definitions for those terms that had previously been agreed to by a previous task force. Okay, after we came up with those definitions, these are the specific topics that we set out to define guidelines for: symptomatic treatment, thymectomy, immunotherapy, impending crisis, MuSK myasthenia, pregnancy, and juvenile myasthenia gravis. So we think that these topics cover the waterfront, and that everything that you need to know about the treatment of myasthenia will be covered by one or more of these topics. I'm not going to go into what the recommendations are for each of these topics, but I'm going to give you a couple of examples of how we achieved, what it took to achieve consensus on the various guidance statements. Let's start off with one in which we achieved easy consensus. But let me just say, it took overall 18 months to achieve consensus on all of the topics. We did this by email, and this was also facilitated by our moderator, who made sure that people got their votes in on time and that they responded appropriately. And that we didn't communicate amongst ourselves. She was great at chiding people tactfully but firmly. So the first topic to talk about is immunotherapy. This was the first statement that we sent around. If high steroid doses are needed chronically to achieve or maintain an adequate response, a steroid-sparing agent should be added, typically along with the steroid, to permit subsequent reduction of the steroid dose to the lowest necessary to maintain an adequate response. We thought it was pretty good, but several of the comments made by the panel members said some things that we thought we could incorporate and make it even better. So being dissatisfied with just okay, we decided we would go for even better. So this statement on the first round vote had a 9, the scale that we voted for was 1 to 9, and we achieved a median score of 9, which is pretty darn good. You can't get any better than that for a median. But there were a couple of votes that were not as high as we thought. And we did achieve agreement, but we modified it, even though we had achieved consensus, and we modified it and then revoted. And this was the second statement. It's not that much different, except we added some comments down here in the bottom about how to define steroid side effects and to deal with what happens with if the symptoms recur when the steroid dose is reduced. And then we revoted on this modified, and we again got a median vote of 9, but now the lowest vote was an 8. So we decided we're never going to get a 9 from everybody. Some people just feel that perfection is not achievable in this world. So we were satisfied with a median vote of 9, appropriateness, and an agreement. So this is the statement that we ultimately ended up with regarding immunotherapy. Now this was, as I say, this was an easy consensus. Now let's talk about a difficult one. Thymectomy in childhood myasthenia. The first statement was this: in children and adolescents aged 5 to 10, thymectomy should be considered only after failure of symptomatic therapy and immunotherapy. Henry, would you have voted yes on this?
No.
Okay, so there you go. We didn't achieve much in the way of consensus from this quick and dirty statement, so we had to go forward with, we got a median vote of 6, but somebody gave it a 1. And the conclusion was that these results were uncertain and equivocal. Go back to the drawing board, which we did. And this was the round 2 statement, modified based on the discussion. Patients under 15 years, thymectomy should be considered in generalized myasthenia after an unsatisfactory response to cholinesterase inhibitors and immunotherapy. Henry?
It's a lot better.
A lot better, but still not that good?
It's pretty good.
Pretty good. Okay, well, who was it wrote the song? No, it was, that on the way to perfect, take a look at pretty good. Okay, but we're not going to do that. We're going to stick on the way to perfect. The second part of this statement was that thymectomy is indicated in peripubertal and postpubertal children with moderate to severe acetylcholine receptor positive myasthenia. And then we came up with a number of statements to deal with specifically seronegative children who might have congenital rather than acquired myasthenia and therefore would not be benefited by thymectomy. And the recommendation that evaluation at a center specializing in childhood neuromuscular diseases should be considered before recommending thymectomy in young patients with seronegative myasthenia. So we really were expanding the recommendation here widely. This got a median vote of 8, but again, there were some folks who were very concerned about it and wanted it even better. So we went back to the drawing board once again, and this was the modified statement based on the second round of discussion. And you can read it. I'm not going to spend a lot of time on it so that we have some time to discuss this. And here we made very specific the risk or the possibility that a child without antibodies might have congenital myasthenic rather than acquired autoimmune myasthenia, and again recommended evaluation at a center specializing in neuromuscular diseases. Okay, and with this extensive modification, we did finally, in fact, achieve a consensus with a median vote of 8, a range of 7 to 9, felt to be appropriate with consensus via P. That took, I think, 4 months, or at least 4 months to get to that point with this one statement. So then we were able to move on with the other statements. So, as I mentioned before, these are the topics for which guidance statements were developed and will be available for you. And I think I'll leave it at that, other than to reiterate that the guidance statements are in press, should be published within the next few weeks, and we appreciate the support of the MGFA, which was critical and instrumental in bringing about this landmark project. Thank you very much.
I'd like to turn to Dr. Massey a bit. In that first example and the second consensus where there was a modification about contraindicated and refused, that seems like that was very focused on the patient's decision-making process. Do you agree, or?
Yes, I agree. And I think the group in general was very focused on ultimate patient care and outcome, if that's your ultimate question to me. And this, I think, one of the strengths that Don was talking about is that this group was a group of people who had wide clinical experience with patients and understood these types of issues. So, Henry, does that answer what
That
you're
definitely
getting at?
answers my question. And Dr. Howard, what do you think about this whole process?
Well, Don and his group have done an absolutely yeoman's job, much like the task force in developing the research criteria, which we use today. This was a huge undertaking, critically needed. All too often we find patients treated by neurologists, good neurologists, who've come to us who have been totally inadequately treated or inappropriately treated. And hopefully this will start to level the playing field throughout the country, throughout the world, as to best approaches and how to manage these disorders. There's no question that the skilled neuromuscular clinician who deals with this disease every day is at the best person to be able to manage these individuals, the complex cases anyway. But hopefully we're going to stop seeing patients who have severe bulbar respiratory disease for 6 and 8 months, treated only with cholinesterase inhibitors and nothing else, which I find absolutely terrible. It's going to have an impact on the third-party groups that Don mentioned, and hopefully make our job easier, as none of the drugs we use have FDA-approved indications for their use. And many of you have experienced the difficulties with your insurance companies having treatments or medications paid for. And hopefully this will start to chip away at that barrier that we all encounter and are frustrated by and bang our heads against the wall with. So overall, and I've not seen the full document, I've seen pieces of it, excellent job.
Great. And so, Dr. Guptill, so you're a pretty young guy still compared to everybody else up here. So you're going to be around a lot. My question for you is, what about dissemination of these guidelines, more than just Chip said? I think there's a lot of expert opinion out there, great review articles, but that still hasn't changed the playing field in many areas of neurology, including myasthenia. Any kind of forward-thinking ways to disseminate these and educate the populace of neurologists?
Well, I think forums such as this at the national conference is a great way to do that. I think through websites as well, through the MGFA, and then possibly other organizations who have an interest in neuromuscular diseases, like the MDA, maybe even the Academy of Neurology too, for the general neurologist population that is out there looking to learn more about how to treat these patients.
And can you elaborate a little bit on how you think insurance companies are going to react to this?
I don't know. That's difficult to predict. I think the major limitation that we face on an almost everyday basis now is the lack of evidence from clinical trial data to support the use of certain medications that we use. And the reality is that type of data is probably never going to come. So I think that this, really fills, a very important need in the community for both patients as well as for clinicians in trying to make a reasonable attempt at how these patients should be appropriately managed.
So the name of the publication is Neurology.
The publication has agreed to make this an open, is this open?
Yeah.
An open access article, which means anybody can go to the neurology website and download a copy of the paper. But I am absolutely sure that the foundation is also going to make it available. If not, we'll have to start ringing some, right? In a little bit of follow-up to this, we're planning a research project for which we have handed out a survey. The purpose of this ultimate research project is to determine how well patients who are treated according to these guidance statements achieve an outcome that patients think is significant. And Dr. Guptill will say a little bit more about this later on today. So the purpose of the survey that you hopefully picked up when you registered is to do a follow-up study to the publication of the guidance statements.
So I'm just going to ask one more question, but hopefully the entire panel can respond to. So you mentioned patient-based responses, right? So traditionally, we've only trusted physicians or designated evaluators. So can you tell me the role of these kind of patient-based evaluators, Dr. Massey, and then everybody down the...
Well, I mean, it's the obvious statement would be that this is trying to assess the living with the disease element of it, which is slightly apart from our assessment in the clinic. Hopefully they are in line, but the two don't always parallel one another.
Jeff?
Jeff?
I guess, thinking about this from a slightly different perspective in terms of developing therapies for patients, if you look back at the past 50 years of drug development, a lot of, as Dr. Kaminski mentioned, a lot of the focus has always been on, well, what do the physicians or the drug developers think about what's important to patients? But, clearly there's been a massive shift towards really engaging the patients to find out what's important to them. And so there are numerous projects that are now focused on that particular area and research grant opportunities to develop and understand patient responses and preferences with regards to their therapy. And I think, obviously, the more that we look into this, the more surprises we're going to find as to, what we feel is important versus, what patients feel is important. And as Dr. Sanders mentioned, that'll be one of the focuses on some of the follow-up research that we're interested in conducting in this area.
That's great. And Dr. Howard, any final comments on that?
Well, just a couple of comments. Jeff is right that for years we've all been focused on what we as physicians think in terms of clinical trials and how one responds. I will tell you that there is a clinical trial that is underway with a complement inhibitor called eculizumab, in which the FDA mandated that the primary outcome measure be patient-reported assessments. One of the first times that's been used. We're using our measures as secondary outcome measures, but it's a patient-reported response that will determine whether this drug flies or doesn't fly. There are many of us or some of us in the myasthenia community that use outcome measures in our encounters with patients. In our clinic anyway, we use all 4 of the commonly used validated MG outcome measures, one of which is a purely patient-reported quality of life instrument. Another is a activities of daily living instrument. And we incorporate that into our assessment, making the patient part of the team, if you will, in therapeutic decision-making. And we would hope that over time, these instruments gain broader, wider use out in the myasthenia community.